All right. So this session is about 45 minutes long. Again, it will be about 30 minutes with 15 minutes left for Q&A, and save your questions until the end. And I will come around with the mic and have you ask it. It is my pleasure to introduce you to Dr. Daniel Cruz. He's a cardiology specialist at UCLA's Cardiovascular Center. And let's give him a warm welcome.
Well, I want to first say thank you to the organizers for having me. I see some patients here, and I have had the privilege of meeting people from as far as Fresno, and so thank you again for coming. The title of my talk is Forecasting Cardiac Events in Myotonic Dystrophy. And so I want to start with, there was a social scientist who is named Philip Tetlock, who did a very interesting study many years ago now. And he was at Berkeley when he did this, but he interviewed experts in the political sphere. These are 284 experts, and they asked them to make 80,000 predictions, right? Just kind of the questions that I was asking you. And the results were kind of surprising that actually they were worse than guessing in terms of how good they were at these were experts at seeing the future, right? So, and as Tetlock put it, these experts are just human in the end. They're dazzled by their own brilliance and hate to be wrong. Experts are led astray not by what they believe, but how they think. So they're led astray by how they think, not by what they believe. And so based on this very important paper, I think it was published in Science or Nature, which is a really big deal, the CIA or DARPA equivalent was like, oh, this is interesting work. We'd like to hear more about how people can see the future. It would be pretty important for our government to tap into that. And so he got a lot of money to start a tournament. And the tournament was asking questions like the ones that I just gave you, but in the political sphere. And all these schools had their teams. MIT had a team, Cal had a team, Harvard had a team, and actually the government had their own team in the CIA, and he had a team. And his team was actually composed of people like you. He had found, because his initial paper, I said that people were worse than guessing, but he actually had found that there were some people who were really good at answering these questions. And so he formed a team from lay people. And the tournament ran for 4 years, and each year, Tetlock's team crushed all the other teams, including the CIA. Right? So they stopped having the tournament because they won so many times. And so these really good thinkers were called super forecasters. And so this is a book, and it came out, it's pretty much, it's over 10 years now at this point, or it feels like it's been about 10 years. And I read it, and it really had a big impact on me. And just kind of a quote that kind of tells you a little bit about the book. It says, most people are terrible at predicting the future, but a small subset of people are significantly less terrible. All right. So I think this talk is really about how do you forecast in myotonic dystrophy? Like, how do you see what's coming? Right? We already told you we're not very good at forecasting the future. So how can we get a little better? Before that, a little preview into the book, which I hope you read. These really excellent forecasters called super forecasters had some qualities. They were open-minded. They were willing to change their minds. They were not dogmatic in the way they thought. They were not necessarily super brilliant. I mean, they were probably pretty smart, but not like off the charts, right? So that gives us a lot of hope, hopefully, right? They analyze problems from the outside view first, and then they went to the inside view. So, for example, for the question in the president's, will the president finish a 4-year term? They might ask the outside view, which is, well, how often do presidents not finish a 4-year term? Oh, that's only like 7% of the time. But then you consider our 2 candidates, maybe we'll move that up to 10% or 12%, right? But they're not going to go crazy and say, oh yeah, 80% chance they're not going to finish that. So they're thoughtful. They take the outside view, say, what are the base rates? And then what does this look like, right? They have a growth mindset. Kind of they learn from their mistakes, right? They know the difference between luck and skill. They know when they got something right and they were just lucky. Like, oh gosh, I got that right for the wrong reason, right? So, and the graph here on the right shows how they update their beliefs. And they make movements on their predictions in small increments. So this actually is a graph of the leading forecaster for one of the years, who I think was a software engineer up in Vancouver. And the question was, will there be 1 million refugees in the Arab Spring? I think that was the question. And the question was open for 3 months and then it closed, and it was going to read out 3 months after that. And so you can see that in the beginning, he just wasn't sure. But with time, as events happen, he would adjust his beliefs. By the end of March, he was very sure that the number was going to be over 1 million. And so he locked in his question almost at 100%. So you see that ability to kind of be flexible. As data changes, you change your mind. And lastly, they showed that when these forecasters worked together, they actually did better. These really good forecasters, they worked well in teams. And so there's a lot of similarities in medicine, a lot of similarities in myotonic dystrophy. And I'll tell you why. So how do we forecast outcomes with myotonic dystrophy? Well, first of all, we talk to you. We gather a history. Has there been fainting episodes? Has there been a lot of palpitations? What's the family history? We do an examination. Is there clues in what we're hearing on the exam? We use screening and diagnostic studies. And we'll talk a little bit about those. And then we keep an open mind as new information becomes available. So if the story changes a month later, please call us, because we can work as a team to update our beliefs, right? And then lastly, we work as a team. So I'm happen to be lucky enough to work with Dr. Sultanzadeh, Dr. Shea, and the other experts in myotonic dystrophy. I'm an expert in cardiology. I do a lot of cardiomyopathy work. I take care of patients with weak hearts. I feel like I'm pretty good at that. I'm not an expert in myotonic dystrophy. These are the experts at myotonic dystrophy. I see a lot of patients with the condition. I know about their hearts, but that doesn't make me an expert. I need to work as a team. I need to learn from you guys, right? I need to listen and, keep updating my beliefs when I'm in this trying to predict what's coming, right? So I'm going to talk about 4 different things. I'm going to spend a little more time on the first one, which is the conduction system of the heart. Then we're going to talk about rhythm abnormalities. And then we're going to talk about cardiomyopathy. And then lastly, coronary artery disease. I want to spend some time on the conduction system because this is kind of the weak link in myotonic dystrophy. It's not, I wouldn't say super weak, but of the ones that I've talked about, this is one that you have to pay special attention to. This is one where the rules are very different for myotonic dystrophy compared to any other patient that I see. It's very, very, very different than any other patient. All the other things, very similar. But this one has its own rules. And if you don't know those rules, you won't be able to forecast very well, right? Okay, so really brief overview about the conduction system. Everybody knows that we have a heart and the heart pumps, but the heart is under the regulation of a pacemaker. It has its own pacemaker. It's not a metal one. It's made out of tissue, and it sits right up there in the right atrium, in that oval-looking thing that's a sinoatrial node, and that's the pacemaker. And those yellow arrows simply are saying the conduction starts here and it's spreading across the atria, the top chambers. Now, once it gets across the top chambers called the atria, they converge on that other oval called the atrioventricular node, or AV node for short. Now, once it gets to the AV node, there's a pause. And that's a very important pause. Okay? The pause is important because the contraction from the atria, from the top chambers, has to deliver the blood to the lower chambers, right? It needs to have that time to deliver into the ventricles. The other thing is, if you end up having a really fast rhythm in the top chamber, like going at 300 beats per minute, and you don't have a gatekeeper, we would all die. We would just fall over when we had those fast rhythms. But that AV node is like a gatekeeper. It says, wait a second, I will only let you conduct so fast and not more. So there's a delay there. It's a natural delay. We all have it. We all need it. Okay, but in myotonic dystrophy, there's a progressive slowing in the AV node, and also in the conduction system below, called the bundle of His, which is right directly below that AV node. From there, it spreads to the left and right bundle branches and spreads throughout the ventricle, and then the ventricle contracts. So the atria contract, pause, empty the contents into the ventricle. Then it's a ventricle's turn. The ventricles, of course, deliver the blood to the rest of the body, right? Delivers it to the lungs, to your organs, right? To your liver, to your brain. And so how do you figure out, well, do I need a pacemaker, right? Do you need a pacemaker? How does one know that? Well, I will go back to saying sometimes it's hard to know, right? So we have to draw clues, go back to the history. Are you passing out a lot? Are you feeling more tired? Are you feeling like your heart rate is way slower than it used to be? So the first thing that we do pretty much on an annual basis, if you're over 40, and maybe a little less frequent if you're less than that, but is we do an EKG. And probably many of you have had an EKG. And on the top, you see all those squiggles, which have little bumps and tall peaks. Suffice it to say that the little bumps are the top chambers, the atria contracting, and the big spike is the ventricle. And the pause in between that little bump and the big spike is called the PR interval. Just think of it as your personal record, okay? PR. You should all know your PR, is what I would say. If you take something away, you should ask your cardiologist, and he might look at you, say, what's my PR interval? And he'll know that you know what to look for. So in patients with myotonic dystrophy, in patients without myotonic dystrophy, only patients with advanced AV block will need pacemakers. That's way down on the bottom. Like if you look down way at the bottom, that's like third degree AV block. You can see there's no rhyme or reason to the little peaks and the big spikes, right? They're doing their own thing. There's no communication. That's called complete heart block. The top chambers are doing their thing. The bottom chambers are doing their thing. That is a common reason why the general population might need a pacemaker. And it's a spectrum. Right above that is second degree AV block. That's also very high degree block. That often gets a pacemaker. But first degree block, which is the one that I'm just showing you right underneath the top one, where the PR is getting longer, we see that all the time. We do not put pacemakers into people for that. However, in myotonic dystrophy, if you have first degree AV block and it's really long, like more than 240 milliseconds, or if your QRS, the peaks are very wide, that actually is a very good reason to strongly consider a pacemaker. This is very unique to myotonic dystrophy. And so you just have to kind of know that. That's why I'm spending some time on this conduction piece. This is very unique. Everything else, there's a lot of similarities, but this one's very unique. Now, your cardiologist might be on the fence. You might say, gosh, you're still young. Do we really want to put in, you don't have any symptoms. It's 239. It's not quite 240. Do you need a pacemaker? You may actually go to an electrophysiologist to do what's called an EP study, an electrophysiologic study. And what that is doing is really trying to ask, well, how sick is that conduction system? You're not quite meeting the criteria for a pacemaker. You're not passing out. How worried should we be? So What you do is you go into the heart with catheters here in orange and blue and yellow, right? And what you're doing is you're using these electrodes to measure the conduction system. So if you measure, if the conduction time from the His bundle to the ventricle is more than 70 milliseconds, that is a sign that your conduction system is a little bit more frayed than we like. And that's a reason to think about getting a pacemaker. So, and while they're there, they might actually try inducing arrhythmias and ventricular arrhythmias to determine whether you might need a pacemaker or a defibrillator. Now, you might say, what's the difference? They look the same on an X-ray, to be honest with you. They're very similar on an X-ray. Pacemaker versus defibrillator. What are they? So we've already said if the conduction system is really slow in myotonic dystrophy, it may be recommended to you to get a pacemaker just in case you have a real slowing that would otherwise could be hurtful. But in some people, there's also irregular rhythms from the lower chambers, or the muscle is a little weaker. And in that situation, you might get what's called a defibrillator. Now, the difference is they both look the same in terms of that circular box. We call it a box that sits on the left side of the chest there. And there's wires coming to that. And the wires go into top chamber, the right atrium, and the other wire goes into ventricle, right? This is a defibrillator, and you know that because there's that bolded area in those wires. You can see it's really bright. Those are called coils, and you can deliver electricity through that. So a defibrillator has the added ability to shock you in case you have a really worrisome rhythm. And they're really smart. They rarely shock you by accident. That's good. But they make mistakes sometimes. So we always consider, like, should we do a defibrillator? Should it just be a pacemaker? And for those of you who have really good eyes, I'm not one of them because I'm 53, and like my eyesight's gone. But you can see number 2, there's a third lead there that's really, really fine. This person actually has a resynchronizing device. And what that means is that the conduction system in the ventricles was a little frayed, and it met criteria for resynchronizing the heart. So if you have a weaker heart and you have a wide QRS complex, you might get a third lead, and that actually can strengthen the heart, not only pace it, but also strengthen it. How many patients get pacemakers? Depending across the studies, there's different numbers written down on the order of 3 to 22%. So think about, I would say roughly 10 to 15% on average might need a pacemaker. You might say, well, how do you decide? I just told you, right? We're looking at the EKG every year. How's your PR interval? How's the QRS complex? We're getting a history. If you passed out 3 times without explanation and your PR is getting longer, you might get a pacemaker recommended. Okay. So I'm going to shift gears to arrhythmias, rhythm disturbances. They sound similar, but it's a little different. Now we're not just talking about the conduction system and how slow it is, but we're talking about whether things tend to be speeding up or getting very slow all of a sudden. Now, you can imagine that if you have slowing, but you don't feel it all the time, and you're trying to figure out, well, did you faint because your heart got slow or because your heart got fast? How do you figure that out? Well, sometimes we send people home with these little patches called Zeo patches. Maybe one of you have worn Holter monitors, right? To look for a day or 2 or 7 or 14 to see how the conduction system is doing at night, during the day, when you exercise. And sometimes we are really a little more worried, and we actually want to monitor you for a longer time. So there's things called implantable loop recorders, which there's an X-ray with a little implant. It goes right under the chest. And that actually can monitor you for about 3 to 4 years. So if your cardiologist is on the fence, like, I'm just not sure if you need a pacemaker, I need a little more information, they may ask for these additional studies to figure out how your conduction system is doing and whether you're having really fast rhythms or slow rhythms. Now, some of these rhythms have specific names, and I think I would say that the details are less important rather than the concept. Some rhythms are more worrisome than others, is all I will say. So if you have atrial flutter, for example, right, that's actually the top chambers are going fast, and it's sometimes really easy to fix with just a simple procedure, like a little burn makes it go away. If you have atrial fibrillation, that one is kind of chaos in the top chambers. And that's important because if you're getting up there in age, like you're over 65, or if you have a lot of risk factors, you actually might need blood thinners to prevent a stroke. So capturing these irregular rhythms is really important. And that's what these monitors are designed for. And that's why we want to hear from you if you're having irregular rhythms at home. Okay. So monitoring, you can, and sometimes people ask, what about wearable monitors? Some of you might have an Apple Watch. They're pretty good. They're not perfect, but I have had patients come in and say, I'm here because my Apple Watch said I had atrial fibrillation. And I look at the data and I'm like, yeah, you did. Sometimes it's like, nope, it's a false alarm. It's not atrial fibrillation. They're just extra beats. But some people really like monitoring their rhythm, and I would encourage you. And it's actually pretty easy these days. You can just upload your EKG into the portal and share it with me. It's pretty easy. You just upload and say, hey, I had this. Just please don't do it 6 times a day. Once in a while is okay. All right. So I spent a little time talking about atrial fibrillation. Now, how do you decide if you happen to have this? How do you decide if you need blood thinners to prevent stroke risk? Well, first of all, I want to spend time on that because it does seem to be a little more common in myotonic dystrophy than the general population. Triggers include alcohol and sleep apnea. So try to keep it down on the alcohol, not too much. And if you have sleep apnea, get it treated because it actually helps the atrial fibrillation not come or stay away. And then the way that you determine whether you're at risk for a stroke if you have atrial fibrillation is by adding up all your risk factors. So if you have congestive heart failure, like a lot of water buildup, or if you have high blood pressure, or if you're older, or you have diabetes or prior stroke, you get a very high score. You definitely need blood thinners. If on the other hand, you're younger than 65, you have no other risk factors, you've taken good care, your blood pressure is good, you don't have diabetes, well then your score is low and you might not qualify for blood thinners. And so there are some things you can do to modify your risks for stroke. And I think that's important to communicate. Imaging of the heart, this ties into the cardiomyopathy, right? Is the heart getting weaker? Many of you may have had an echocardiogram, which is the most common way that we look at the heart. It's just an ultrasound, and it's there on the top. Images, it tells you your ejection fraction. And again, your ejection fraction should not be 100%. That's the amount of blood that your heart's pumping out of the body out of the heart to the body. And normal is about 55 to 65. 50 is kind of considered low normal. And it's a number that you might just know. What is my ejection fraction? And there's also cardiac MRIs, which can quantify scarring if you use gadolinium, but it can be challenging to complete because you have to hold your breath for a little while. And they're also harder to get to. And I don't necessarily think you have to have an MRI every year, but periodically can add value if it's going to affect your treatment. So the treatment, if you do have a weaker heart in myotonic dystrophy, it's slightly different. I'll explain why. So in other muscular dystrophies, we know that if you start treatment early, when you see left ventricular dysfunction, you can slow the progression and sometimes even normalize the function. So if you have myotonic dystrophy and your ejection fraction used to be 55%, and you come in the next year and you're 48%, right? That would be enough to start thinking about taking a little cocktail of medicines to strengthen the heart again. And these medicines that we've used in the general population actually have very good effect in patients with myotonic dystrophy as well as other forms of dystrophy. So that is similar treatments as a general population. Up to 40% of patients will develop LV dysfunction, but in my experience, it's usually not like so severe that we can't help it. So I think that's good news. As a cardiomyopathy specialist, I think myotonic dystrophy tends to respond well. It usually does not get super weak, and we can usually help with the medicine. So I think that's good news. Guideline-directed therapies apply. We've talked about that. We started early. Now the blood pressure can be a little bit lower in myotonic dystrophy. So I want to be careful. I don't want to use huge doses, right? I want to use tiny doses. Watch your blood pressure, make sure you tolerate the medicines. And then if you don't have a pacemaker defibrillator, there's a class of medicines called beta blockers, which can slow your conduction. So I'm a little extra careful with beta blockers because your conduction system may be a little frayed. So just a little caution with that. Lastly, I do want to talk about the arteries. Now, the heart is a muscle. It's pumping, lots of times every day, and that requires energy. And the energy is delivered to it through arteries that actually feed the heart. And most of you know people or have loved ones that have had heart attacks. That is when an artery that's supposed to look clean, like the top one, develops a bunch of plaque, right? That's called atherosclerosis, and it looks kind of like fatty. That's because there's a lot of fat in there. It's cholesterol plaque and the immune cells that are gobbling up the fat and gets trapped in there. Now, the way this happens is that your quote unquote bad cholesterol, your LDL, is getting trapped in the wall. So we want to keep your LDL in the reasonably good range. But LDL does pretty good if you don't have a lot of risk factors. If you're not smoking, if you don't have terrible blood pressure, if you don't have diabetes, if you don't have a terrible diet and things like that, LDL can just kind of live with you and not cause any trouble. But if it builds up, then we treat it like we do other patients. We might put a stent to open up that artery, or we just might treat with medicines if there are any symptoms. So the recommendations are not really different for myotonic dystrophy. As I said, want to limit the risk factors, and if you have limited exertion, like if you're not exercising as fast as you otherwise would, sometimes we have to do chemical stress tests to see if there's actually significant blockages. We might ask for an angiogram to actually look at the arteries, or a CT coronary angiogram, which is just a CT that is gated on the arteries that tells us how clean are your arteries looking. And some patients with myotonic dystrophy really want to avoid statins. Statins are cholesterol-lowering medicines. You can use them safely, but I share the concern and I try to use them at small doses. And I stress healthy eating and lifestyle as much as possible so we don't have super high cholesterol. So as much as you can, modify what you can so we don't have to use big doses of medications. But we can use statins in myotonic dystrophy. I didn't spend any time really distinguishing between the two. One reason is that I leave that to Dr. Sultanzadeh, to the subtle differences. On my end, I really think of both patients in the same way because they're really prone to the same cardiac problems. Maybe myotonic dystrophy presents a little later in onset, but to me, it doesn't make a difference. I'm going to be screening you pretty similarly. Okay, I'm going to close with my Super Forecasters is probably one of my top 5 books, but this is my top 1 book. This is my favorite book of all time. And I do want to close with this because I think it's also a little bit of a philosophy to practice medicine. It's also a philosophy on life. The title of the book is Anti-Fragile. Now, that is a strange word, and it's not really a word, but the author came up with it because he looked at every language that has ever been spoken for a word that was opposite of fragile. And can anyone think of a word that is opposite of fragile? Anyone? Sturdy, strong. Now, it turns out those are not the opposite, because when something is fragile, what happens to it? If it's a glass and you hit it with a hammer, what happens? It breaks. So what would be the opposite of the glass breaking? It would actually grow stronger. That would be the opposite. You would hit it and it would grow stronger. And there isn't a word to capture that, right? There's no word that captures that. You hit it, but it gets stronger. But we know it exists, right? We know, your grandmother knows it exists. She says, if it doesn't kill you, Makes you stronger. Your grandmother knows it. We know it because when we're trying to gain strength, we might actually put on a little weight, right? We might injure our muscles. That's what we're doing, right? We're causing tears in our muscle. And what happens on the other side? It grows stronger. We all know that if we just sit around, is that good for our muscles? That's not going to be good for our muscles, right? So we know the concept exists. We know it's all around us. And so it's interesting because this book actually references Tetlock. And his idea is that forecasting is good, but it's also weak because we're not very good at it. It's better to create systems that are basically going to grow from insults. So as much as possible, take each system and say, well, what can we do? Gosh, I can't predict whether you're going to need a pacemaker or not. If I see your PR interval prolonging, or if you fainted, how can I strengthen that? Well, at the least I can make it more sturdy by putting in the pacemaker, right? So that we don't take that fragile system and make it more fragile, right? That's what you're doing with the EP study. You're looking for fragility in the conduction system. So we're trying to get clues at what is fragile to try to strengthen it. But I think that so regular screening might help us detect areas of fragility. Once we detect it, we can try to turn those weaknesses into strengths. I also think you can adopt a healthy lifestyle, and that can make a major difference. If you can control your risk factors, it's tough. I mean, there may be a signal for higher diabetes in myotonic dystrophy. You got to be extra good with your carbs, right? You got to eat extra healthy, right? It's a burden, but take that into this predisposition might make you think, I'm going to eat way better and avoid it. I'm going to turn that weakness into a strength, right? And then I think it also applies to medications, right? If you don't want to expose you to things that could have risk. If I give you a big dose of a, ACE inhibitor, I might drop your blood pressure and make you more fragile. So we want to be careful. We want to give you just enough to strengthen the heart, but not more so that we make you more fragile. So I think, and I do think the heart has its own anti-fragile properties. Your hearts are, by and large, pretty strong. They are finding a way to keep going. They're finding a way to stay strong without my help, right? Most often. I'm just there to help the small percentage of people where the heart's kind of falling behind because the heart is trying to heal itself, okay? I think my job is way easier than Dr. Sultanzadeh's for sure, because I think the heart has anti-fragile properties. So I do believe in that. I believe that our bodies have ways to repair themselves, but we have to help it along, do the right things with your lifestyle. And hopefully we're there to help you if the area of fragility gets a little bit too much. But hopefully that helps explain how we think about myotonic dystrophy, and I'll be happy to take any questions.
Oh, thank you, Dr. Wow. Okay, guys. Thank you so much, Dr. Cruz. All right, I'm going to start on this side and I will come around here, and there.
Hi, thank you. It's been the last 4 months of heart stuff for my husband, starting with low blood pressure. After one day in the hospital with low blood pressure, he coincidentally had a heart attack. And then they did, I think, a stint because he was 99% blocked on the right side. But the blood pressure being low continues even with midodrine, is that how you say it? And now another one, a steroid called Fluta something. Anyhow, is that normal with myotonic dystrophy? It doesn't, some days are worse, some days are better. But what causes that and what can we do? Because now he's supposed to have this healthy heart, but if you can't walk around, it doesn't really feel different.
Yeah, thank you for the question. And I think I'll repeat it just in case some of you didn't hear, but sometimes the blood pressure gets low. And I mentioned that with myotonic dystrophy, the blood pressure can run a little low. So you have to be careful. People have to know to prescribe small doses of medicines to strengthen the heart. And sometimes the blood pressure is too low and you need to add medicines to strengthen the blood pressure. And midodrine and fludrocortisone or Florinef are two that can be used. And I think what I'll say is that sometimes when you're going through an acute illness, the blood pressure gets extra low. So things that you can do to support that would be make sure you're well hydrated. If you take a medicine that lowers your blood pressure, Do you need it? Right? Take it away, right? When you have long periods of immobility, the blood pressure tends to drop. Your autonomic nervous system often will kind of get a little lazy. And so, it turns out that any one of us, if we lie in bed for a month, we're all going to have autonomic insufficiency. Our body needs to have changes in position to kind of strengthen. So what I would tell your husband would be work with compression stockings, body binders, mitogen, Florinef, and get moving safely, right? Because that's going to be what helps him restore his vascular tone again. And in the process, don't have a fall because it can be dangerous. So it can get better. Again, sometimes these are transient after an acute illness, but it doesn't usually get better if you're not moving, right? Even if it's going from the bed to sitting in the chair, that's progress, right? And then from there, you start standing up and marching in place. That's huge progress, right? And so little by little, that tends to get better. So again, this idea of anti-fragility, you insult the system, it gets better. It's all around us, right? You just have to look for it, right? So, but you need those challenges of pushing it every day, or it won't get better.
Thank you, doctor.
Yeah.
You spoke about the left bundle block being you need a pacemaker. What about a right bundle block? Is it different or perhaps more dangerous? Because I've been told I have a right bundle block.
Yeah. Thank you for the question. So, yeah, the right bundle branch block is similar to the left bundle branch block in that one of the bundles is blocked, right? The His bundle divides into two, right and left. Traditionally speaking, we think of the left bundle as being a little more clinically relevant. But again, I think that's really important. In myotonic dystrophy, the rules are a little different. They're just a little different. So I don't think that you can ignore a right bundle branch block without really thinking a little more deeply about how the rest of the conduction system is doing, right? So in a case like that, you may just question, like, how is the PR interval? How, maybe wearing a monitor for a little longer, maybe doing a loop recorder to say, do I need a pacemaker? Maybe I'll watch a little more closely in a situation like that, right? And so that's, I don't think that in the general population, often right bundle branch block is relatively benign, but it deserves more investigation. What was that? Yeah, we're on the fence a lot. These are hard questions, right? And we are looking to be to make the right forecast, because we also don't want to just put pacemakers, because that's not fun either, right? So I can understand why someone would be on the fence. So you need to be nudged a little bit.
Hi.
Hi.
I already have an ICD. I got it at 49, and it's a miracle. But I had a question. I had it because of profound bradycardia. I also have AFib, cardiomyopathy, and a left bundle branch block. So I'm wondering if it goes the other way, like because it's handling everything, and my EP is almost normal, but I'm wondering if it can adversely affect the myotonic dystrophy, just having this, even though I have an ICD and it's taking care of it. Do you know what I mean?
So I think your question is that you have an ICD, you have a history of left bundle branch block, atrial fibrillation, and is the presence itself of having a device, can it actually worsen the condition? Is that?
Yeah.
Yeah. It's a really important question. So I think the answer is it can, and you have to ask the question, why, so if you have a left bundle branch block, right, and you have a 3-lead system called CRT, resynchronization, then we are trying to pace the heart every beat. That's a situation where we want to pace the heart every beat, right? It's different than if you have a defibrillator or a pacemaker and it's there just in case you have block. It's a very important difference, because in that situation, we don't want to pace your ventricle. We just want to be there on standby mode. So lots of patients with myotonic dystrophy, they have pacemakers and defibrillators, and their activity level is very low. It's just kind of watching them. So it really depends on the clinical situation. I'm super happy that your heart's gotten stronger, right? And I think it's almost normal. So whatever you and your cardiologist are doing, keep it up.
The medication.
Yeah, exactly.
But, it is pacing me. I mean, I feel sometimes like it's going low, and then I wait a few minutes and I'm fine.
Yeah.
So it is, you know, every day, I guess, every minute of every day, it's keeping me alive.
Thank you.
Hi, thank you for this talk. It was really interesting. As you were talking, I was looking over at my records on my phone for my EKGs, and there's been a trend where each year they go up. They're still, the last one was at 230.
Yeah.
Is that a trend that's going to continue, or with lifestyle changes, could it go back down? Or
Yeah, no, I think that, you know, this is not something that you did. This is part of the condition. And that's why we actually ask you to come back once a year to get an EKG. And 230, you know, as I said, 240 with QRS widening, that by itself can be an indication for a pacemaker. Once you're in the 230 range, you actually, you know, it wouldn't be unreasonable to consider an EP study, right? Just to say, you know, hey, how is my conduction system? I just want to make sure it's still holding steady, or maybe even a closer monitoring strategy. And so, yeah, I think that if you see the trend, that's actually why I spend so much time on the conduction system. I think that's what makes myotonic dystrophy in our world particularly unique. You have to pay a really close attention to that.
Hi, Dr. Cruz. My question is that, so we see a cardiologist for my daughter. The challenge that I feel I face with my doctor is that we don't know if he's watching for the right things for myotonic dystrophy, right? So we try to point certain things out, and so on. He dismisses it a little bit. I mean, he may be talking based on experience, but I guess from your perspective, what is the at least the monitoring in the heart, is it different for someone that has myotonic than just any other patient? Or is it more just the myotonic is just different as far as the treatment? How would you describe that?
Well, I think I'm an adult cardiologist. I want to begin by saying that I don't treat congenital myotonic dystrophy. So I would caution just me and you to say the same rules apply to your daughter. So having said that, I do think that the disease pathophysiology has similarities, and you know, we are thinking about the same things in terms of conduction abnormalities, and that's why to your point, you should know what your PR interval is. You should know that when you're getting closer to 240, or if there's a fainting episode, you can't ignore that, right? You can't simply say, oh, it was the sun, right? You have to take a good history with fainting episodes. And so I think you may just make sure that the cardiologist works with your neurologist and they have a good relationship, right? We're a team. And so, you know, hopefully you can be sent to someone who's seen, you know, it's a rare disease. So I wouldn't say that I have hundreds, but I've had the privilege of seeing a good number of myotonic dystrophy patients. So I think I've learned what to look for over time, right? So you're right to say that not every cardiologist knows these things. So I would say that's fair.
Last question. Thank you, Dr. Cruz. Also, Myotonic Dystrophy Foundation on your page 9 has a clinical care guideline for cardiologists that you can get and give to your cardiologist as well. Last question.
Yeah. Well, I mean, I think that, you know, there's a reason why I spent, I mean, I think I'll repeat the comment, which is your cardiologist isn't looking at the PR interval. And I have to be honest with you, I think before I started seeing patients with myotonic dystrophy, I would have missed it. I mean, it's just that simple. Unless you're really in this world and you know, like, oh, this is really unique, right? It's just so much out there. It's not, I don't think the cardiologist, it doesn't make them bad. It's hard to keep up with everything. So you probably just have to say, okay, here's a page from the Myotonic Dystrophy Foundation about things that I should be looking for. Can you review and tell me what you think, right? And hopefully that would prompt them to dig in a little more. There's there's nice review articles that they can look at. And we're always learning. You know, like I said, experts can be wrong a lot. So I think that we need to work as a team, and you're part of the team.
All right. Thank you so much, Dr. Cruz, for this excellent session.